Hello and welcome to another Intensive Care at Home and Intensive Care Hotline emergency Q&A for our clients and for their families. Thank you so much for coming on to the show. My name is Patrick Hutzel from Intensive Care at Home and intensivecarehotline.com. Hi Elaine, I can see you're here. Nice to see you again. So before we dive into today's questions or any comments that you have or any questions that anyone on this live stream has, what makes me qualified to answer questions for families in intensive care or families with intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background. I have worked in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And we've been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And I can confidently say that we have saved many lives as part of our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com, or you can look up our podcast at intensivecarehotline.com, where we've done client interviews. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, and also for otherwise medically complex adults and children and adults and children that are dependent on BiPAP, CPAP, adults and children that have a tracheostomy but are not ventilated. We also provide home TPN, home IV potassium infusion, home IV magnesium infusions, port management, central line management, peak line management, as well as Higgman's line management at home. We're also sending our critical care nurses into the home to avoid emergency department admissions and emergency department presentations. With Intensive Care at Home, we are currently operating all around Australia. We are NDIS accredited, TAC and WorkSafe approved in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the DVA all around the country. And we also have received funding through public hospitals, private health funds, and departments of health. Now, first off, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button if you want. Share the video with your friends and families. Share your comments here so I can answer your questions and know what videos to make. Without further ado, let's dive into the first question. I also want to welcome our viewers on LinkedIn, Rumble, X, and Facebook. Now, without further ado, let's go to the first question or a comment that comes from Zagreus, who says, "Hi Patrick, I recently spent 11 days in ICU and 6 days in an induced coma, acute pancreatitis caused by alcohol abuse. I was on a ventilator being given propofol and remifentanil. Wild experience," he says. "Delirium is no joke, and I've got days worth of hallucinations that seem real to me. Before going to ICU, I was already being given strong stuff. I was on fentanyl using a PCA. PCA means patient-controlled analgesia, and I loved it. And detox medication, and who knows what else. I spent a total of 17 days in hospitals. I have almost zero memory of about 15 of those days. Just a bunch of craziness in my head that I've been going over again and again with my partner to figure out what was real and what wasn't. Even knowing hallucinations were actually hallucinations doesn't change the realness of them in my brain, and considering almost all of them were bad, I don't think I'll ever truly get over it. I've been out of hospital for 4.5 weeks now. Alcohol-free, will never drink again and still think about what I thought, heard, and saw all the time. I don't think anyone can truly understand how traumatic it is unless you've been really through it. Well, thank you so much, Zagreus, for sharing your experience here with our audience and with our families in intensive care. And also, maybe ex-patients are watching this, but, at no point in time are you saying you regret having gone through it. And at no point in time are you saying, that you didn't want to live because you went through it, because that's what often intensive care teams imply, that, going through the struggle of recovering in intensive care is not worth the effort because patients won't have any quality of life, or what I would say, they won't have any perceived quality of life. Quality of life is a perception, no more than that. And obviously, you are well enough, Zagreus, to send an email like this, which is really good and beneficial for our audience here. Thank you for sharing. Now, if you have any questions while you are live on the stream here, type them into the chat pad or join me live on the StreamYard link here, and you can answer your questions live on the show here and talk to me directly. I will be going roughly for an hour. So we are 6 minutes in now, so we've got plenty of time to answer your questions. If you don't have any and you just want to listen in, I have plenty of questions that have come in during the week. So I will just keep reading them out. Hi, Alatham. I think I was talking to you last week. If you still have questions, join me live on the StreamYard link, or type them into the chat pad here. I remember you were here last week. Okay, so before I read out another question, I just want to quickly give a story from this week, actually. Working with a client one-on-one, a very distressed client called this week saying their 77-year-old mother has gone into ICU on the 14th of July with an aspiration pneumonia after uncontrolled seizures. She ended up in ICU and was intubated pretty straight on with the aspiration pneumonia, as she could no longer maintain a safe airway and as she had difficulties breathing. She then got extubated last Thursday, which would have been the 25th of July. So she was basically intubated for 11 days. She got extubated with a view of the intensive care team telling the family it's going to be a quote unquote one-way extubation. Basically what that means is if a one-way extubation means you take the breathing tube out and there's no going back in case a patient can't breathe, which could then develop into a palliative care situation. But the family really didn't know what that meant, and they couldn't get their head around it. And cutting a long story short, the intensive care team then extubated her on Thursday, and pretty much the same day was bringing in the palliative care team and start the conversations about end of life with the family, saying, well, she won't improve, she won't have the breathing tube back in, let's just start morphine and midazolam and let's quote unquote make her comfortable. And with her being made quote unquote comfortable, that could have moved her towards end of life pretty quickly. Now the family wasn't content with that and realized, oh, if they don't stop the morphine and midazolam, she gets more and more drowsy, her breathing became more and more shallow. And that's when they reached out to us here at intensivecarehotline.com, basically saying, is it normal that a patient after extubation should be moved to palliative care so quickly within less than 24 hours? And is it normal that an extubation is a quote unquote one-way extubation without a view of putting the breathing tube back in case patient fails extubation, right? So in any case, when we looked at the situation much closer, we thought it is very inappropriate to tell the family within less than 24 hours of extubation that palliative care is the only option here, and that by stopping morphine and midazolam, that there's a very good chance their mother might wake up, right, and that their mother might improve. But with morphine and midazolam on board. You know, when you look at palliative care overall, especially in the ICU world, morphine and midazolam hastens death, right? It makes people drowsy. It makes people stop breathing. And, one could argue, when you look at the definition of euthanasia is the hastening of death. One could argue that by giving morphine and midazolam, it's hastening death. Now, there are exceptions to the rule, of course, and if someone chooses palliative care and they don't want to suffer and they don't want to be uncomfortable, then morphine and midazolam are perfectly fine. But that wasn't the case in this situation. The family had not been consulted. The patient, whose first language isn't English, hadn't been consulted. So the intensive care team had a lot to answer for in terms of what their next steps were. To make a bad situation worse, she was also not getting any nutrition, right? Because they took out the nasogastric tube while they were extubating her. So she was without nutrition for 24 hours a day. And we then advocated for nutrition as well. Yesterday, I was in 2 lengthy family meetings with intensive care teams, or with the intensive care team, advocating for what was right and asking, why has there been no informed consent? So what I mean by that is, for a patient in ICU, there needs to be an approach of informed consent. So what I mean by that is, patients and families need to be informed about the treatment they're receiving, or potentially the treatment they're not receiving, right? And none of it had been the case here. So, when we asked, okay, what medications is the patient on, they also stopped the anti-seizure medications, putting her at higher risk to develop more seizures, which, on the 14th of July led to aspiration pneumonia because she wasn't taking the medication at home. So all these issues need to be addressed openly and transparently when you have a loved one in intensive care, so that things are not being brushed under the table, which was the case here, and lo and behold, after many after discussions and asking questions, not only does the family now get access to the medical records, which is also something the hospital was trying to delay. Now, the patient is now on full treatment. They stopped the morphine and the midazolam. She seems to get more awake, more alert, more aware of her surroundings, and now she can express what she wants for herself. There's a number of concerns here in terms of, what's the rush? Where's the rush in killing someone? Where's the urgency in that? I don't quite understand that, why ICUs are always so negative and wanting, to move certain patients towards end of life as quickly as possible without giving them a good go, without giving them best care and treatment and see what happens. So thankfully we were able to turn that situation around, like we have turned many other situations around, just by simply asking questions and holding intensive care teams to account. Now, Elatham, you're saying, I contacted a patient advocate at the hospital and she helped us get a PEG tube for my dad and tracheostomy scheduled for next week. Elatham, I do remember talking to you last week, but I have to admit, I do not remember the ins and outs because I'm talking to so many clients every day that I don't remember all the ins and outs. So if you can give me the background of your dad's situation again, that would be good. I would be very, very, very hesitant to give consent to a PEG tube if I was you. Very, very hesitant. And you also have to keep in mind, if you contact the patient advocate at the hospital, they're still a hospital employee. They're not on your side. They're not. They are a hospital employee with the label of patient advocate, but they're actually not on your side. I've done countless of videos over the years where I strongly, strongly advise to potentially give consent to a tracheostomy, but not give consent to a PEG tube. Do not give consent to a PEG tube. Like I said, I do not recall the ins and outs. I know you were here last week, but I'm talking to so many people every day that I do not recall the ins and outs of your dad's situation. Maybe you want to jump on the call here, give me the brief of your dad's situation again, or type it into the chat pad. 9 times out of 10, we strongly advise against the PEG tube. And there are many, many reasons why we advise against the PEG tube. So jump on the call. You've got the StreamYard link here, or type into the chat pad, what was your dad's exact situation? I don't quite remember. All right, in the meantime, if you have any other questions, type them into the chat pad while you're on this call, or join me live on the StreamYard link here and you can talk to me directly. If you have no questions at the moment, I will read out a question from Ravi that came in during the week, who says, hi Patrick, my child has double pneumonia and now she's on BiPAP and the breathing pattern is not normal. Right, okay. I'm very sorry to hear that, Ravi. I think what you might need to do here is check out whether BiPAP is the right ventilation setting for your child. I would also ask for an arterial blood gas here. I would ask for chest X-ray results or potentially CT scan results of the lungs, right? And BiPAP may not be the right thing here. Other things that come into play here is your child having a tracheostomy or is your child having a breathing tube? If they're having a breathing tube and they're on BiPAP, it might be uncomfortable and they might need more sedation, which generally speaking, I'm not a big friend of, but that is what might be needed in a situation like that. Or your child might have a tracheostomy and they will probably be off sedation if they have a tracheostomy. And if the breathing pattern on BiPAP is not normal, maybe they do need a little bit of sedation, or they need to be changed to a different ventilation mode depending on arterial blood gases, definitely depending on the breathing pattern, depending on chest X-rays or CT scans of the lungs. Right, so BiPAP is a good option when carbon dioxide is high. BiPAP is a good option when different pressures are needed in the lungs, right? But I don't know the ins and outs there. Again, arterial blood gases, chest X-ray or lung CT scan would be the best next steps here, and then reach out to us again so that we can help you with the next steps. Now, Helene, you're saying, Patrick, can fentanyl and propofol also be used for induced respiratory failure or end of life? Can fentanyl and propofol also be used for induced respiratory failure? What do you mean by induced respiratory failure? You know, respiratory failure can come in all sorts of sizes. You know, I'm not sure what you mean by induced. Can propofol and fentanyl be used for end of life? Fentanyl, absolutely yes. Propofol might be used for end of life, but probably not so much. It's probably mainly fentanyl and midazolam that are being used for end of life. Fentanyl and propofol are definitely being used for respiratory failure, but I'm not sure what you mean with induced respiratory failure. Respiratory failure usually comes in two types. Type 1 respiratory failure is lack of oxygen, and type 2 respiratory failure is high carbon dioxide. Right, that's usually how respiratory failure is being, the distinctions that are being made between two different types of respiratory failure. I am not sure what you mean by induced respiratory failure. Propofol is usually being used for short-term sedation, right? So that it can be taken away quickly, because if propofol is taken away quickly, it also means that if propofol is taken away quickly, patients wake up quickly. That's why it's often not being used for end-of-life care. Okay, Latham, you are saying heart attack, cardiac arrest at work on the 25th of June, estimated downtime 10 minutes, discharged or diagnosis with anoxic brain injury on CT MRI, has been on the ventilator for a month, no seizures, on EEG report breathing over the ventilator. Yeah, okay. So Latham, I'd say with what you are sharing with me here, and I actually believe that last week when you and I spoke here, that I did advise for a tracheostomy from memory, because it's been too long. You know, no one should be on the ventilator for more than 10 to 14 days. Your dad has way past that, right? He's way past that. And from that perspective, absolutely yes to a tracheostomy, but absolutely no to a PEG tube. And here is why, Latham, no to a PEG tube, right? No to a PEG tube for the following. I know you are in the US. I know that you're in the US. I think you're either in Connecticut or in New York. I can't remember, but you're somewhere on the East Coast from memory. So if you do a trach and a PEG, there's a very high chance your dad will be sent to ELTAC. Very high chance for that, right? You do not want your dad to go to ELTAC, right? If your dad ends up with a tracheostomy but no PEG, most ELTACs can't take him. He can just stay with a nasogastric tube and he'll be perfectly fine with a nasogastric tube. There's no need for a PEG. The very reason why the so-called patient advocate in the hospital has most likely advised you for a PEG is that they want to send him to ELTAC, and that's in the interest of the hospital, but it's not in the interest of your dad. But they're not telling you that, of course, right? Patients in your dad's situation can have a nasogastric tube for months on end. There's absolutely no issue. I encourage you to have a look at ELTAC facilities or have a look at their reviews online, right? And then you tell me if you still want to send your dad to an ELTAC facility, right? Unfortunately, I would not trust a patient advocate in a hospital unless they are 100% independent, and they're not. I'm 100% independent. I've got nothing to gain here, whether I advise you one way or another, whether I advise you to do a PEG tube, no PEG tube. I have nothing to gain from that. But a hospital advocate, that's an employee of the hospital, has something to gain from that. So Latham, you're saying he's tolerated CPAP for 5 hours, vent settings, PC, AC, FiO2 40% PEEP, 6 pressure support, or pressure set 26, respiratory rate 14. Okay, so that means he's nowhere near to be extubated yet because he's still alternating between CPAP and the PC-AC mode, which means he will need a tracheostomy after all this time. Oh my goodness. They did the PEG tube already. They did the PEG but no tracheostomy. Have they done the tracheostomy as well? Have they done the tracheostomy, Latham, or just the PEG? Latham, I think I can help you so much quicker if you come on the call here. Not yet, it's next week. It should have been the other way around, Latham. It should have been the other way around. You see, this is what happens when families don't get the right advice. They're setting themselves up for failure. They're setting themselves up for failure. It should have been the other way around. Not having a tracheostomy after day 10, day 14 of ventilation is negligence. It's absolute negligence. And now you've backed yourself in a corner. Now you've backed yourself in a corner because the minute your dad has a tracheostomy, they will start talking about LTAC, and you do not want your dad in an LTAC. You absolutely don't. All right, guys, if you're watching this, this is what happens when you leave getting advice too long, or if you don't do your research. You know, that's what happens. You're backing yourself in a corner because you don't know what you don't know, unfortunately. Right? Yeah, that's what happens. You know, if you have a loved one critically ill in intensive care, you need to do your research right from the start. If you don't, this is what happens. You're making mistakes and you don't even know that you're making mistakes. And there can be life or death mistakes. All right. Let's get on to the next question. that's come from James. Oh no, hang on, this is not. Yes, let's read. This is the next question here. That comes from Yogita. Yogita says, "Hi Patrick. Firstly, I would like to thank you for your excellent service that you're providing for critically ill patient loved ones and their families. My dad is 64 years old. It's been a week since my dad has been on the ventilator. At night, my dad started gasping for oxygen and told me that he can't breathe. I took him to hospital. He got unconscious after he was given oxygen. His SpO2 was at 60% at that time when I saw on the monitor. My dad has a history of major heart problems, and he has now 15% of heart functioning only. A year ago, he was put on the ventilator with the same problem. His lungs got filled with fluids because of his heart not functioning properly. And that's what's happened now also. After some time, I saw the emergency doctor giving my dad CPR. They gave him CPR for about 3 to 4 minutes. Then they told me that he got his heartbeat back. Then they put him on a ventilator. His vital signs were stable after 2 to 3 days of ventilation support. His blood pressure finally became stable after 2 to 3 days. Even after the sedation are off, my dad is still not waking up. He got ventilated on the 7th of June and sedation was off on the 10th of June, and it's the 14th of June now. Doctors told us that it's unusual that these things are happening, and they did an EEG and a CT scan of his head. The EEG reports are as follows. Impression: abnormal EEG report. Abnormal EEG record suggestive of severe diffuse encephalopathy. Please explain me, is it like a severe thing? Will my dad be able to walk and talk after this condition? And how much days or month it can possibly take in order to wake up? I'm attaching a whole summary and reports of his condition. Please go through it once and please let me know what else I can do for him in order to wake him up, because the neurologist is saying that it's just a matter of time and you have to wait. And they are also saying he's still critical even if his vitals are now normal. I'm not able to figure out what is in the reports. Please explain to me the EEG and the CT scan reports. That would be a big help to me and my family in such distress. Me and my mum have observed what his eyeballs are, that his eyeballs are very slightly moving. When we try to talk to him, it's a very little slight movement of eyes, but we feel positive about it. Please help me out. I am in so much stress right now. Thank you for helping people in situations like that. Right, so I'm just looking at the EEG report. EEG obtained. It says background activity, delta activity, no focal generalized epileptiform discharges, impression, abnormal EEG record suggestive of severe diffuse encephalopathy. Now, encephalopathy, when someone is in intensive care, it basically means that there is brain disease that alters brain function or the structure even, right? And that can go hand in hand with seizures, twitching. You've described the twitching, you know, when your dad is awake. It could also go hand in hand with personality changes, right? But the question is, why does your dad have the encephalopathy? You know, what's causing it? You know, what's caused the encephalopathy, right? Encephalitis, which is an infection of the brain, can cause encephalopathy, right? But also, for example, you know, metabolic encephalopathy can be caused by liver failure, for example, right? Or it can be caused by an infection, like I said, can be caused by a brain tumor. So the question is, what has caused the encephalopathy? Is it a chronic and traumatic encephalopathy, right? from the hypoxic brain injury after the CPR, right? Those are the questions here, right? So, coming back to your question, your dad also needs to have his heart checked out. If he's got an ejection fraction of 15%, you're saying your dad has a history of major heart problems, and he's now got 15% of heart function, which means his ejection fraction is probably at around 15%, which is not very high, right? So that is another risk for your dad needing another ultrasound of the heart, for example, right? Also, with the ejection fraction only 15%, what are they doing? Are they giving him milrinone, dobutamine, dopamine, levosimendan to get the strength of his heart back, to improve the contractility, to improve the ejection fraction? Because that is the underlying issue that has led to a cardiac arrest, that has led to a hypoxic brain injury, right? So again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care, which is exactly what you are dealing with here. So you are asking, how long will it take for your dad to walk again, to be going back to normal? And I know every family wants that answer in a situation like that. So here's the thing. First off, the underlying issue needs to be fixed, needs to be improved, right? i.e. the heart function, right? Then you need to talk to a neurologist and get their take on the situation, right? Next, the other question is your dad still on any sedatives, right? Is he still on any opiates, or is he completely off sedation, completely off opiates that could potentially stop him from waking up, right? Now, I presume your dad is still on the ventilator, right? Yes, it is what you're saying here, right? But the question here once again is, how much ventilation support is he on? If he's off sedation and his heart is strong enough, can he be mobilized? Can he get out of bed? Can he have physical therapy, right? Those are all questions you should be asking, right? In a situation like that. Very important questions to ask. How long will it take? Depends how quickly they can get him out of bed, how quickly they can stabilize the heart. Talk to a cardiologist. Talk to a cardiologist, Talk to a cardiologist, talk to a neurologist, get a list of the medications, and then get back to me and then I can help you from there, right? But you need to ask the right questions here, and you need to get all the right information. Again, the biggest challenge for families in intensive care is that they don't know what they don't know. Okay, let's move on to the next question. And this question dates back from June. That's how far back my questions are going. So if you need help here more urgently, you need to give us a call or send an email, and sign up for one of the consulting options for the membership. Then we can help you really, really fast. I'm getting so many questions every day. Okay, Alatham, you're saying the LTACs in my area have a higher rating than the hospital my dad is at. Okay, fair enough. Maybe you do have something there that could work for you. By all means, But I would still not have given consent to a PEG tube. I would not have given consent to a PEG tube. There's research out there that say the complications from a PEG tube are much higher than the complications from a nasogastric tube. Right? That's just my extensive experience, you know. And if I was you, Latham, I would have a look in the ELAC. You know, it's good that they've got good reviews online, but I would have a look for myself. I would go into the facility if I was you and have a look for yourself. Right? So, next question. From Mark. Mark says, "Hi Patrick, my dad's in ICU ventilated. He has high blood pressure when he's being weaned off the ventilator and they need to resedate him. It looks like he's stuck in a vicious cycle." Okay. Mark, thank you for sending that through. You know, I've looked after hundreds, probably thousands of critically ill patients and their families in intensive care. So I've seen this over and over again. What often happens is when someone is being woken up, when they come out of an induced coma, when they're on the ventilator with a breathing tube. And if your dad is high blood pressure when he's waking up, it means he's probably not quite ready to be woken up, you know. But also, what might happen is your dad might have an underlying condition of high blood pressure that's being left untreated, that hasn't been diagnosed as yet. He might need to be started on some antihypertensive medications. That could be one way forward, right? But it could also mean that he's simply confused, agitated. He doesn't quite know what's going on, even though they might be talking to him, right? And they might be talking to him with all good intentions, but he might not be ready to wake up just as yet, right? That sometimes happens. Sometimes it takes a few attempts for someone to be woken up. Bear in mind, when someone is critically ill, their body is literally being tormented, you know, and that's when people are simply needing time out, you know. So what's the solution here? I would argue one of the solutions is look at antihypertensive medications, right? Look at, you know, him getting good nursing care, and also when he's waking up, you know, family helps when they are around. It does, you know, the doctors and nurses can talk them through waking up calmly. That often helps, right? And often it's only a matter of, you know, a few attempts, and then things eventually will work out. If for whatever reason things don't work out and he's still agitated, he can't wake up properly, he probably needs a CT scan of the brain or an MRI scan of the brain or an EEG, just making sure and ruling out there's no stroke or any other epilepsy happening. Okay, so that would be my advice there, Mark. Okay. Latham, you are saying, what are you saying? You're saying, yes, Hartford Hospital has been extremely neglectful with my dad. My mum said they don't do nasogastric tubes at the hospitals here unless it's temporary, like 1 to 2 days. It doesn't matter what they do. You can always ask for what you want. You know, it sounds to me like you're intimidated by them, which is not a good starting point. It doesn't matter whether they do it or they don't. You just ask for what you want. You can control that. And if you think you can't control it, you have a problem. You have a much bigger problem than your dad being critically ill, because you don't think you can control the outcome, which is a much bigger problem to have. You know, doesn't matter what they say. It matters what you say. That is what matters. Right? So, let's go back to the next question. Who comes from Hang on. Okay, next question is from Nick. Nick says, myself, after 21 days in a coma, came out with ICU psychosis and delirium. I saw the nurse in my coma's dreams torturing me. I woke up, he was in the room, looked me in the eyes and told me he was going to drop me out of a life flight to my death. I sat there 12 hours awaiting to be killed. It took my loved ones a long time to convince me it wasn't real. Right. I'm very sorry, Nick, to hear about that. You know, you get different stories from people that have been through the ICU delirium. Some people don't remember anything at all, but it sounds to me like you do remember very vividly of what was happening. But again, you're also not saying you wish you weren't alive now. You know, I think that's also really important information, you know, because again, ICU teams say, oh, you know, people shouldn't be going through all of that, but you're not saying you're not happy to be alive. You know, yes, you've been through, you know, what you would probably describe as hell, but that doesn't mean you don't want to be alive. You know, that's really, thank you for sharing. Thank you for sharing. Okay, next question from Stephen. Stephen says, hi, Patrick. My sister has ADS and is being given palliative care after she has been in ICU for pneumonia for only 3 days. This seems wrong. Can you please explain? Well, Stephen, thank you so much for sharing. You know, in the beginning, when I first started today's show, I was talking about a client that we're currently working with who was also in palliative care after she got extubated for an aspiration pneumonia, and where we said, no, that's wrong. And the family thought it was wrong because initially, you know, they were told they would be extubating their family member and then, you know, they would move on to continue giving her best care and treatment. And then it turns out they were moving her towards palliative care, towards end of life care, without informed consent, without getting consent from the patient or the family, without getting consent from anyone really, you know. And it sounds very similar here in your sister's case, that it's just wrong and way too early. Palliative care can happen if there's an advanced care plan, if patients and families are in agreement that palliative care is the best option. That is when actually palliative care is a good option, but that doesn't seem to be the case here, Stephen. And if I was you, you know, I don't know whether you are the next of kin or the power of attorney, I would get access to the medical records as quickly as possible. I would, you know, seek a second opinion, which we can give you, and I'm sure we can turn that situation around, similar to what we're doing with one of our current clients, where, you know, it is not acceptable to move towards palliative care without patient or family consent. You know, again, like I said in the beginning of this show, where is the urgency to kill someone? Where is the urgency to kill someone? What's the rush? Why can't we continue providing best care and treatment until we can be certain it no longer works? Why can't we be asking patients and families what they want? Where is choice and control? Right? So these are all considerations. And I would also, if I was you, Stephen, I would ask the hospital, I would ask for the hospital policy. I would ask for the hospital policy of their palliative care guidelines, end of life care guidelines, and see whether they are potentially breaching their own guidelines. I can almost bet money on it that they do. You can't just move someone to palliative care without getting their explicit consent or the explicit family consent. That could be perceived as euthanasia. It could be perceived as murder even. right? You have to open your eyes, and you also have to apply common sense. Always apply common sense, right? It's a big problem that families in intensive care don't apply common sense because, they know they're sometimes being lied to, and yet they are, not applying common sense and what feels genuine. Right? What feels genuine. All right, let's move on to the next question from Diana, who says, "Hi Patrick, I just received a call from my mother saying she received an alert from the hospital letting my mum know they moved my father to the cardiac intensive care unit and they think he needs more specialized care. They told her he was having trouble breathing, so they are putting him on the ventilator again. He's bringing up lots of phlegm and they think this is the best thing for him. I feel like we've taken a step back and I'm very nervous. Can you advise on if you think this is the route we should be taking or what other questions I should be asking tomorrow to verify this information?" From Diana. Diana, I remember your situation very well. I know you've been a client previously, and I know that your dad had a tracheostomy, and I remember that he was getting an infection, a chest infection. I remember that he had a very weak heart. I remember that his ejection fraction was very poor, and therefore he more or less needed ICU again. And I remember that we at the time advised that this was the best option. And I know he improved after going into ICU a fair bit because, and here is why he improved, because he ended up getting inotropes. He was getting dobutamine and some milrinone, and I also believe he was getting some levosimendan, and that is why he kept improving at the time, right? And that's why it was a good idea for him to go back into ICU. And I remember that your dad made big improvements while he was going in there, right? And I remember this was also a client where we helped them to go back from LTAC back to ICU. This is a US client where we helped them to go from LTAC back to ICU after he received very poor care in LTAC, and he should have never gone into LTAC in the first place. So let's move on to the next question, or if you have any questions here while you are here on the show, type them into the chat pad or join me live on the StreamYard link. You can use the StreamYard link here. Use the StreamYard link here or type your questions into the chat pad if you want to talk to me directly. Let's move on to the next question. That's coming from Sue. Oh, Alatham, you are asking how can LTAC patients go back to ICU? Yeah, there's a few ways how LTAC patients can go back to ICU. Let me explain that to you. So, most LTAC patients that we see go back into ICU are not what you want, and I'll tell you why. Many LTAC patients go to LTAC prematurely, right? And because they go to LTAC prematurely, they're not stable enough. They often bounce back into ICU within 24 to 48 hours, even though we often advise for not letting them go in the first place. There are a number of issues out of that. A, ICUs send patients out prematurely and unnecessarily. Well, if they're bouncing back within 24, 48, 72 hours, clearly their clinical judgment was off and they were just sending them out to free up a bed they didn't send them out because it was in the patient's best interest. I don't think that LTACs are in the patient's best interest. Right, that's number one. Number two, if patients go from ICU to LTAC and then they leave and go back to ICU, we often see that patients bounce back to a different ICU because the discharging ICU no longer has a bed available, right? So that means patients go from ICU to LTAC and then go back to another ICU within a few days. That, in my professional opinion, is madness. That is madness, and it's negligent. Imagine your dad goes from ICU to LTAC to another ICU within a few days. A patient like your dad, Elatham, needs stability. He needs a stable team around him that cares for him, right? He doesn't need to go from place to place to place. It's very taxing for someone in your dad's situation. Your dad is extremely vulnerable, right? He's extremely vulnerable, and therefore he needs stability. Now, there's another way how patients can go from LTAC to ICU. We have helped many families in LTAC getting their loved one back to ICU. But how do we do that? Well, we give a second opinion. We look at medical records. We talk to doctors and nurses directly. And the advice often is, well, that patient would be much better off back in ICU because most patients shouldn't be in LTAC in the first place. Right? I've made a video a few months ago, 10 reasons why LTACs are a scam in the US. Google that and you find a video about that. And I'm not mincing my words. I stand by what I'm saying. LTACs are a scam. Right? Okay, so let's read out the next question from Sue, who says, my son died in ICU. He says, hi Patrick, my son died in ICU when the nurses A, had his bed around the wrong way and B, didn't monitor him. He died of hypoxic brain injury as his tracheostomy got blocked when they were changing shifts and did not monitor him after we had left him. We had to get the nurse to clear his tracheostomy 3 times during that day. Unfortunately, this happened after we had gone home, so we couldn't get help. He was getting better and they were going to remove the tracheostomy the next day as all his vital signs were good. They haven't given an explanation and the coroner said he died from a fungal infection. When we questioned this, they said that they had no information from ICU, only info from his admission. We know he died from his brain injury, but they will not admit it. Also, they were supposed to put a cold blanket under and above him to try and preserve his brain. He knew we were there when we arrived, an hour after the incident. They only put his blanket on top of him and put the other one in the cupboard. I'm writing this as a warning against ICU nurses who do not monitor patients 24 hours and spend most of their time on their phones. I have lost 2 sons to bad ICU care. I am devastated. Thank you, Patrick, for the help you are giving to families with loved ones in intensive care. They must listen to you. Kind regards with a heavy heart from Sue. I'm so sorry, Sue, what's happened here. That sounds terrible. And it beggars belief to me that what's happening here, right? If he died from a hypoxic brain injury because of his tracheostomy got blocked, that's another reason why we are saying with intensive care at home in particular, that patients need 24-hour intensive care nurses and nothing less than that. Nothing less than that. Now, Elatham, you are asking, is it possible to refuse sending a patient to LTAC from the ICU? Now, before I give you a straight answer, if the ICU tells you to jump off a bridge, would you be jumping off a bridge? I'm sure you've answered that by now. If the ICU asks you to send your dad from ICU to ELAC, would you do that with all that you know? You know, right. So you control the outcome. But if you don't believe you control the outcome, you know, there's very little I can do for you. Very little I can do for you. Right? So you need to stop thinking that you can't control the outcome. Because if you think you can't control the outcome, you won't. If you think you can control the outcome, you will. Someone famously said, if you think you can, you can. If you think you can't, you can't. But you choose. And please make a wise choice. Right? You're saying in one of your other messages, Latham, you're saying, my mom said they don't do nasogastric tubes at the hospital here unless it's temporary, like 1 to 2 days. Doesn't matter. You choose. You tell them what you want. You do your research and you tell them what you want. Right? So you need to start you need to start changing your thinking here very quickly. Very quickly. Because if you don't, they'll be walking all over you. Do your research. Don't give consent to something that you haven't done enough research on. You can confidently give consent to the tracheostomy, but you should have never given consent to the PEG tube, never. And do not let your dad go to ELAC until you feel 100% comfortable that this is the right step. Okay, I am going to wrap this up here in a minute. I want to thank you for watching. Also want to thank you for watching this on replay. If you didn't make the live stream, if you like my videos, subscribe to my YouTube channel for regular updates. Give this video a like, click the notification bell, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have. And leave a small donation here on the YouTube super chat button as well. If you want me to do a video for you, let me know and I will get to it very quickly, because the emails that I've got sitting in my email inbox are from, last year still. So I can barely keep up. If you want your question answered here in a couple of days, just leave a small donation and I will read out and answer your question here live on a video. Now, with Intensive Care Hotline, we have a membership for families of critically ill patients in intensive care. Go to intensivecarehotline.com and join our membership, or go to intensivecaresupport.org directly for the membership. I also do one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly. I also represent you in family meetings with intensive care teams. We do medical record reviews in real time. We also do medical record reviews after intensive care. If you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send an email to support@intensivecarehotline.com. If you want critical care nurses in the home, we provide intensive care at home for long-term ventilated adults and children with tracheostomies. And we also provide BiPAP ventilation at home, CPAP ventilation for patients without tracheostomies. We provide tracheostomy care at home for patients without ventilation, home TPN, home IV, potassium, magnesium infusions, port management, Hickman's line management, central line management, peak line management. We do all of that at home as well, including palliative care, ventilation, weaning, and we're also providing an emergency department bypass service, and all of that you get at intensivecareathome.com. We also provide level 2 and level 3 NDI support coordination for intensive care at home. We are currently operating all around Australia with intensive care at home. Now, thanks again for coming onto the show. Thanks for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I will talk to you during the week again, and I will do another YouTube live here next week at the same time. Look out for the notification. Take care for now.